I think it's all about networking, right? And getting to know people and building up your confidence.
Do you ever have so many questions and no one to ask, so they're just wasting away on Google searches you'll forget about in an hour or so?
We had that same problem, and that's why we created the RD2BE podcast, a resource for dietetic and nutrition students looking for answers that their peers don't have.
We are students Macy and Emily and registered dietitian Carl Barnes. We engage in conversations and learn from RDs.
Join us weekly as we gain insight into the unique journeys of registered dietitians all over the country.
Welcome back to another week of the RD2BE podcast. I'm your registered dietitian host, Carl Barnes. This is our weekly podcast where we sit down with a different registered dietitian each week to highlight and really showcase the diversity of opportunity in the profession. The real goal here is to dismantle the notion that there is a traditional career path in our profession. There's so many dietitians doing amazing work across so many different fields. Super honored to be sitting with a colleague today. We actually had the honor of working together with the Leadership Institute recently. So we're joined by Sara Hendrix. She's going to explain a little bit about what she does in her practice and also a little about her leadership role. So thanks so much for taking time to be here with us today.
Yeah, thanks so much for having me. Just to give you a little bit about my background, I've been a dietitian now for about 15 years. I did my undergrad at the University of Arizona in Tucson, and then I did a combined MS-RD program at the University of Georgia in Athens. So we did our academic work during the year, and then the internship was split up between the 2 summers, so 3 months each summer. So that was great. I'm glad I did that. I went on to work initially as a clinical dietitian in a hospital. I started out in the ICU. I think my master's helped me there. There was a whole new crew that started at this small hospital, and because I had my master's, they felt like I could take on the ICU. So huge learning curve there. I did that for about 7 years, and then I was ready to kind of move on and do something a little bit different. I wanted a little bit more of a long-term relationship with patients. And so I'm now working outpatient doing cystic fibrosis care.
Great, thank you. So you mentioned that you did the internship in the summers. So how was that broken up? Like, were you a little weary going back into the internship, knowing that you've had a semester off doing schoolwork, or how was that?
No, I think we were ready for it. During grad school, I was also working on my thesis. And so I did a lot of community involvement. I worked in senior centers, educating members there. And so I think, after 9 months of that or so, we're ready to actually get into the field and practice. So I thought it was a great way to split it up.
So what made you want to do Georgia's program opposed to a different MSDI?
Yeah, so I had a great advisor in my undergrad who, talked to me about how a master's was probably going to be required at some point, and she really encouraged us to consider that. And so I was looking into an MSRD program. At the time, I was more interested in sports nutrition, and I heard that UGA had a good sports nutrition program. And so they were my top pick. I matched with them, luckily. Got there. I did not match with the sports advisor. My primary advisor worked more with older adults, which I ended up loving, and I ended up getting my certificate in gerontology. So I think you always have to be open, to anything that comes your way.
Most definitely, especially because you don't know what you don't like until you come across it.
Right. I found out how much I really love talking to older adults when I did this. So
I didn't think I would really like older adults either, but this time last year I worked in a lab at UMD working with the older population. I'm like, wow, I like this. I did not think I would, but
they have a lot of wisdom to share. Yeah.
They do.
Yeah.
So I noticed that you also have that you're a certified nutrition support clinician. So what does that certification entail?
Yeah, so dietitians, as well as other healthcare providers like physicians, nurses, pharmacists, can take an exam to demonstrate that they have the skills and knowledge needed to provide enteral and parenteral nutrition support. So that's tube feeds and IV nutrition. And the exam is administered by the credentialing board for Aspen. And Aspen stands for the American Society for Parenteral and Enteral Nutrition, if you've not heard of them. But I decided to get certified after I had spent a couple years in the ICU. And I was responsible for managing both tube feeds and parenteral nutrition in critically ill patients. And so this was just a way for me to strengthen my knowledge and also confidence in providing nutrition support. To prepare for the exam, I gave myself a couple months to study. I used the Aspen self-assessment program for study materials. So this can be purchased online, and it's a set of modules with practice tests on all the topics that are covered in the exam. So it's a great resource. For the test itself, I think it took me a couple hours to complete. And I want to say the cost was around $400 at the time. Like the RD exam, it's computerized, although unlike it, you have to wait about 4 to 6 weeks to get your results back. So that's probably the most nerve-wracking part. And then the certification is only good for 5 years. So you have to retest to stay certified every 5 years.
So since you got that credential while working at a hospital, did the employer pay for it? Or did you have to pay for it, especially because every 5 years you have to continue?
Yeah, that's a good question. And it's going to vary. At my facility, like I said, I work for Sodexo, and they're very supportive of dietitians. And so they not only paid for me, but I also got a raise when I got that certification.
Great. So before having this credential, did you have any issue with, I don't know, a doctor or anybody listening to your advice for enteral or parental nutrition?
Yeah, so that's something you'll run into in the ICUs. You have some physicians that are just set in their ways. And actually, when I first started working in the cardiothoracic ICU, where we did heart and lung transplants, but we also did esophagectomy. So patients would have to have part of their esophagus taken out because of cancer or something. And their standard protocol was to do TPN, which is IV nutrition in those patients. The thing is, their gut worked. So if your gut works, you want to use it. And so it made no sense. It puts patients at high risk for infection and complication. And so over time, we were able to show the evidence that these patients can have feeding tubes placed at the time of surgery, and we can feed their gut. And so I'm happy to say that is now the standard of practice over in the ICU. But I don't know that necessarily having the certification helped me. It was the knowledge of it and being able to show them the studies that was the most helpful.
Of course. So I know that now you work in cystic fibrosis. So what made you want to pursue that field?
Yeah. So, it's funny that came really by accident or by chance, I guess. So I had been working in ICUs for probably the first 7 or so years of my career. And I was just ready for more interaction with patients over long-term basis. And so at the Medical University of South Carolina, where I work, we have a lot of different specialty areas. We have about 30 different dietitians, and a colleague and friend of mine was getting ready to move and suggested that I apply for her job, which was in the cystic fibrosis clinic. And so that was aligning with what I wanted to do. And so I did that, and I've been here for about 8 years now.
Great. So what have you learned in a clinic? What have you learned from learning in a clinic that specializes in your specific category?
Yeah. Well, so let me back up and just say, in case people aren't familiar with cystic fibrosis, just a little bit about what it is. So CF, it's a genetic disease, and it affects the cells that produce mucus, and also sweat and digestive enzymes. And in the lungs, that mucus plugs the airways and can cause infection and inflammation and then lung damage over time. In the pancreas, the buildup of the mucus prevents the release of digestive enzymes that help the body to digest and absorb food. So then this results in oftentimes malnutrition, vitamin deficiencies, poor growth. So these are all the reasons why the dietitian is so important to the CF team. But to answer your question, I found it so much more rewarding than I ever thought it would be. Because CF is a chronic disease, patients come to clinic every 3 months for their checkups, and I work with both pediatrics and adults. So I see patients from birth, and then I think our oldest patient is in his late 70s. And we have, as a care team, we are like second families to a lot of these patients. I've been to dance recitals, I've been to graduations, weddings. It's just been a really cool experience. And now is a really exciting time for CF because there are new therapies available that target the genetic defect in CF. And so it's changing the way that patients live, changing outcomes, and just a really cool time. As far as learning, how to manage patients with CF, I will say, there's a big learning curve initially, but there's so much support out there. And I think this is similar for any specialty, clinic or disease. So we have the CF Foundation, which is a wonderfully supportive organization. They have tons of resources for us. There's this huge CF Nutrition 101 document that we get when we start. There is a mentor program, and the CF Foundation pays for all of that. So after a few months of being here, I got to go shadow a dietitian at a similar clinic in Cleveland, spend a few days with her and see how things worked. Learned a lot from that. And then there's a great listserv too. So any silly question you have, you can post to the listserv and get a great response within minutes. So lots of support out there.
Most definitely. So who makes up your CF team?
So we have a large team. CF is a very complex disease, and it takes a whole team to manage patients. So we have physicians, pharmacists, respiratory therapists, social workers, psychologists, genetic counselor. And then we also have some consulting team members. We have a GI doctor. We have an endocrinologist who manages diabetes, physical therapists, and I'm probably leaving out some, but it's a very, very inclusive team.
So how is it working with such a big team?
It's the best. I love it. My team is like a second family to me. So we're very close knit. We travel together. We attend conferences together. We work on projects together. So whether it's research or quality improvement projects, we're very involved in the local CF Foundation. So we're actually planning a kickball tournament for next month to raise money and awareness for CF. So it's a really great experience. And then as far as how we work together to treat the whole patient, we have team meetings before every clinic. And so we discuss each patient and we discuss what their biggest concerns are. So, with so many different team members, we don't want 8 different clinicians going in and coming up with a goal for the patient. That can be very overwhelming. And so we try to get on the same page before we see the patient and decide what we want to focus on. For example, if the patient's been losing weight, the focus may be nutrition. And I may go in with the psychologist or the social worker and address some of the barriers to why they're not getting the nutrition they need. Other times, maybe their lung function is down. And so this is all about the respiratory therapists, working with them on their therapies.
Of course. So what is the most challenging part in working with CF people or people who have CF in your clinic?
Yeah. Well, so there's a lot of great things on the horizon for patients with CF, but we still have some with very severe disease. So some patients don't have some of those new therapies that are available because they have very rare mutations. And for these patients, CF is still a life-shortening disease. And so that's the hardest part when a patient succumbs to their disease, especially after we've been working with them for years and gotten to know them. And then the other thing that's hard is that we all have these ideas in our head about what is the best thing for the patient. If only they would just do their tube feeds every night or take their enzymes before all their meals, then they could gain weight and be healthier. But the truth is our patients have hours of therapies that they are supposed to do every day. And their priorities may be different than mine, right? So you really have to learn to work with the patient where they are and accept that adherence is not a patient problem, it's a human problem. I mean, how many of us get our recommended amount of sleep every night, our servings of fruits and vegetables, our minutes of exercise? So yeah, it's hard to do it all, and it's important to just learn to work with the patient where they're at.
It definitely makes you want to have more than 24 hours in a day.
Exactly.
So I'm sure that, there's new information coming out about cystic fibrosis all the time. So what type of continuing education do you do or research do you participate in to stay up on the latest information for your patients or clients?
Yeah, so our major learning event is we have an annual CF conference that about 4,000 or 5,000 of our closest CF clinicians all go to every year, and it's great. It's like a 3 or 4 day conference, and they break sessions up by discipline. So they have sessions that are focused on CF nutrition or physical therapy or nursing or social work. So that's a big one. I go to that every year. But there are so many opportunities. One of my first projects that I did here was a nutrition telemedicine study. So it was focused on parents of children up to age 4. And the reason that we chose age 4 is because we have a lot of evidence to show that if kids can reach a healthy weight by age 4, they do better later in life. So better lung function, less hospitalizations. And so I focused on these parents, and we did nutrition telemedicine over a 6-month period. I met every other week for the first 3 months, and then I think monthly for the last 3 months. And each time I had a nutrition topic. So I focused on things like high calorie baby food. And then I had a behavioral topic focusing on like positive meal times. And then I surveyed participants before and after the study, and we found that their nutrition knowledge improved, the feeding problems, the reported feeding problems decreased, and then weight improved too. So, that was a great project. That was something I presented at our national conference just to share with everybody else. And then more recently, I just did a project. Weight's an important thing in CF. We know that weight and lung function are directly linked, and some of our patients just can't eat enough calories with diet alone to maintain their weight. And so we have a small percent, probably 10% of our patients have feeding tubes, and they get tube feeds overnight while they're sleeping. The problem is, like I mentioned before, their enzymes, or their pancreas doesn't release enzymes. And so they have to take enzymes by mouth to be able to break down and absorb food. And that's hard to do with nighttime tube feeds because enzymes only work for about an hour. So we're not going to have patients wake up every hour and take enzymes by mouth. So anyway, there's this new device that was just released probably about 5 years ago now. It's a cartridge and it has enzymes in it, and the formula runs through it, and the fat is broken down, and what's delivered to the patient is absorbable fat. So it's just such a great thing. So we were one of the first places to use it in the country, and so I just made sure I kept track of all outcomes. And then I just wrote this all up and submitted it to a journal. So, and that was accepted, and that'll be published hopefully soon. So,
Great,
yeah,
congratulations on that.
thank you.
So so I don't really know too much about CF. We touched a little bit on it in school, but a lot of your patients spend time, are they mainly in the hospital or are they out of the hospital? Because I know you mentioned about 10% do tube feeding at night. So I don't think they can do that at home.
They can.
Oh,
They can, yeah. But that's a good question. And honestly, if you asked me 2 years ago, it would have been a different answer. But because of these new therapies that are out, they're medications that basically are targeting the genetic defect in CF. So very close to a cure. And like I mentioned, they're changing outcomes for patients. So patients that maybe used to come into the hospital every couple months for what we call a tune-up because their lung function's down and they needed to be treated with IV antibiotics, they're not coming in as much. They're staying well and they're able to stay home. So we really don't have too many admissions anymore. Of course, we do occasionally. I have 2 in the hospital right now that I'm following. But that's lower than it used to be. We used to have, 5 or 6 at a time. So things are getting better. But yeah, with the feeding tube, they will have feeding tubes that are placed directly into their stomachs. It's called a PEG typically. And it just looks like a little button tube, and they just hook up to their pump at nighttime and run their feeds while they're sleeping.
okay. So I know that you work also with the adult and the children. So what population do you think, in your opinion, is harder to work with?
That's a good question. So, when you work with pediatrics, you're really working more with the parents, right? Depending on the age. We actually have a great transition program. We really try to get our kids involved in their care from an early age. And starting at age 12, we really focus on transition. We get them to know their medications and, eventually how to call in refills and things like that. But I will say, earlier on, it's more the parents you're dealing with. So it's a tough one to answer. I enjoy working with both for different reasons. I guess you just have to remember that only as much as the parents are willing to do will it get done for the pediatric patients. And that's the hard part because, the kids just can't do some things themselves.
That's definitely. So this is a little bit, I don't know if you would know much about this, but obviously CF is, like you said, digestion, breathing, stuff like that. So how has that been affected with COVID, if at all?
Yeah, that's a good question. So we were really worried, at the start for our patients. But what we found is that our patients have already been practicing social distancing and masking before COVID started. So there are infection control guidelines for people with CF. And so all patients with CF should keep at least a 6-foot distance from each other. And that's because, like I said, that thick, sticky mucus they get in their lungs traps bacteria, and there's different bugs. Some bugs are worse than others. And so we don't want patients sharing bugs with another patient with CF. So that's always been the rule: keep a 6-foot distance, mask up when you're in clinic. And then they do several breathing therapies a day to kind of clean out their lungs. And so we've been very lucky as far as how our patients have done. We've had a couple patients that have gotten COVID and did okay. And I think that's because they're already doing so many protective therapies and they're already social distancing too.
That's great. I mean, I didn't really know how much, and obviously you said therapy and stuff like that, but I didn't know what that really entailed. So they were ready. They were ready for
Yep,
COVID.
they were.
They were already practicing.
Yeah.
So I know you worked in the ICU. So what are some unexpected things that you came across in the ICU that you think students should be prepared for when they either become dietitians or even go through their dietetic internship?
Yeah. Okay. And I don't know that necessarily that I found anything unexpected. I just kind of learned as I went. But what I will say, it's going to be a different experience from place to place. What's important is that you make yourself known as a dietitian and the nutrition expert. So you don't want to be the ghost dietitian going around writing your notes and hoping that, somebody will read them and follow your recommendations. So it's really important to speak up. You are the expert, and work on becoming the expert, right? So join different organizations, whether it's the Academy or Aspen, where you can be on groups and you can hear all the latest research and data around, nutrition support if you're in the ICU, is a big one. Because I remember when I first came to MUSC, I did have to struggle to get my voice heard. I think there was high turnover in the dietitians, and I kind of had to fight my way into the group, and made sure I was showing up for rounds, which is when all the providers get together and talk about each patient at the bedside. So I think just making your voice heard is really important.
So as a past president of South Carolina, you've had leadership experience. So what do you think, or I guess that's twofold. So you've had plenty of leadership experience, and I'm sure that you didn't get your voice overnight. So what things did you do to really try to stand out while you were an undergrad, a graduate student, to set you up to be a successful leader?
So I always loved being involved. In undergrad, I think I was president, I'll have to look back, president of the nutrition club at the time. And I think it's all about networking, right? And getting to know people and building up your confidence. So I just took every advantage that, I could find. And I think I also communicated with my advisors, let them know what I wanted to do. And I think because of that, they really pushed me to, run for certain clubs or organizations and things like that. So I think just taking every opportunity that you can to make those networks is really important.
Definitely. And as someone who obviously has a good, strong clinical foundation and background, what advice do you have for students who are trying to get into hospitals right now, but it's still a little hard? It's getting better, but just what advice do you have for those?
Yeah, it's been a tough couple years. But again, I'd say take advantage of all opportunities that you get. It can be hard to connect virtually, but we've all learned to adapt and make the best of it, I think. We were talking a little bit earlier about the Leadership Institute through the Academy. So I had the opportunity to do this. It was starting in the fall of 2020. So it was all virtual. But I made so many connections across the US, including Carl Barnes, that we met with weekly and really, got to know each other. And now we're just excited to see each other in person at Fancy sometime. So I think you just have to make the best of it as far as the virtual opportunities.
Great. Well, thank you so much for taking time out to speak with us today. I really appreciate it.
Of course, happy to. Well, good. Well, thank you for having me.